Thank you. It's really great what you and your companies are doing. Okay.
Good job.
Do you have Danny?
Yes.
Yeah. Okay, so I'm really pleased to introduce our next speaker, Dr. Danny Goel. Dr. Goel is a clinical professor at the University of British Columbia's Faculty of Medicine in the Department of Orthopedic Surgery. He received his medical degree from the University of Manitoba and completed his residency training in orthopedic surgery at the University of Calgary. He further pursued fellowship training at both Western and Harvard University. With over 50 publications to his name, Dr. Goel has made significant contributions to various topics such as patient access to care, health economics, and skill transfer using virtual reality. He is also the founder and CEO of Precision OS, an immersive VR simulation platform that is transforming the way medical professionals train and develop their skills. So please join me in giving a warm welcome to Dr. Danny Goel.
Thank you. Hi, good morning, everybody. Thanks for being here. So I'm going to take a little bit of a more conservative approach to VR. Probably explains why I'm wearing a tie, and hopefully you all can hear me. Okay, so I want to talk about the data behind VR, and I consider this to be a really powerful technology. And I want to take a little bit of a different lens here, because what we're doing is we're trying to impact patient care. So if we keep that in the center of our conversation of our minds, how do we use this technology? And of course, here's my disclosure. I saw this from the movie Moneyball, because I think this resonates true with medical education, surgical education. It's unbelievable how much we don't know about the game we've been playing our whole life, and Mickey Mantle said this. And it seems, and that could actually cause a complication to the groin area for men and women, which is really important. But what I'm learning here is I'm learning how to think three-dimensionally during surgery. Is I can open up the hip, I can put the hip in adduction, but I'm creating that mental model and parallelizing that experience with what I see during the actual x-ray in the OR. Now, I'm not a hip surgeon, I'm a shoulder surgeon, but what I'm going to do here is I'm going to try to find that lesion using this needle, because this is the first way that, this is where you can put your camera in and your burr in. And so I've identified it, but I've made a bunch of mistakes during that time, which is how we learn. We actually learn through failure. And so what I'm going to do now is I'm going to take my arthroscopy skills, because I do camera surgery as a shoulder surgeon, and I'm going to apply them to this hip virtual patient. And I'm going to go ahead and I'm going to start resecting that lesion, that bone lesion. And I think I can see it. I'm pretty clear on what it looks like. I'm using X-ray to parallelize that experience. And then what I'm going to do is I'm going to take it out of the hip now to reinforce what that X-ray looks like to what I actually think is going on in 3 dimensions. This is the power of VR in my mind, is how do we get a surgeon to think 3-dimensionally while looking at images that are only there available in 2 dimensions. And of course, as mentioned by previous speakers, the collaboration is quite powerful in VR. Look what I've done here. I've failed because I took away so much normal bone that I actually could have harmed that patient in real life. This is the kind of stuff that I think matters when you're talking about VR. So we're going to talk quickly through research. I've got about 5 minutes. So the questions that we should be asking, I think we need to be careful the questions we ask, because they drive the research we do. So who can benefit from this? So this is a study done at Toronto that looked at anatomy, and anatomy is very 3-dimensional. And they randomized 50 medical students to half of RVR and then half to a cadaver, crossed them over, and then had them do an exam at the end. And what they found, this paper submitted for publication, their outcomes were equal. Their learning outcomes were equal when you study on a cadaver versus studying on our anatomical specimen. The thing that's missing here, though, is they used a curriculum, which is important, because you don't just put somebody in a cadaver lab, throw them on a headset, and don't give them any guidance. The curriculum is a really important part here, and more about that in just a minute. This study done out of Calgary, where they took 2 groups of residents, these are senior residents, and said, we want you to dissect. The question was, we want you to dissect to a point of safety before you do this procedure. Half of them did it in VR, the other half read how to do this procedure from a journal, and they randomized them to 2 groups, and they put them in a cadaver lab. In the cadaver lab, they were evaluated by orthopedic surgeons who did not know what type of education they had, and the end point was safe dissection to the next point of the procedure. And wouldn't you know, so the red line is the group that read, and the blue line is a group that actually did VR. So there's truly an acceleration or a bending of the learning curve through this study. And that was published in JBJS, which is one of the leading journals in orthopedics. Then they took a different group of orthopedic surgery residents, these are in their final years, and said, okay, we want you to see, if you watch a video, are you gonna go and operate? Can you actually operate by watching a video? Because we do that all the time right now. Randomized 2 groups, half to VR, half to video, and said, okay, now we're gonna actually have you do the procedure on a cadaver, but this time we're gonna make the cadaver abnormal, simulating what it would be like in real life. So they took a big chunk of bone out of part of the shoulder to see, can you actually reconstruct it? And this is what happened. The blue is the precision group, and they measured errors. Look at the error bars in the VR group compared to the non-VR group. And of course, the idea here is, okay, so if you understand this correctly, I spend more time watching a video, and I made more surgical errors, and the simulation is more expensive. That, to me, is where this technology has power. Can you compare surgeons? You know, low and high volume surgeons. That was a question that was asked out of Ireland, and they did a really elegant study looking at novice and expert surgeons. And wouldn't you know, the expert surgeons still removed normal bone, whereas the novices, they just took a big chunk of the bone away from the neck of the femur. And the problem with that part of your femur is when you take away bone, you can actually cause a fracture, which is devastating in a young person, absolutely devastating. This is another study also done out of Ireland showing that can you compare using a score, so now we're getting into proficiency, how surgeons that are high volume compare to those that are low volume. You can see it's stark, it's very clear that in this hip fracture module, the experts always perform better, and that's exactly what you need to benchmark a procedure. What about the optimal learning environment? I always think that the residents are very happy in the OR with me, but they're not. This is a study done also out of Midlands, showing that when they took a group in VR and had them supervised with an attending, their heart rate actually went up, they burned more calories, and their performance went down. And so this, if you multiply that by the experience in the operating room, it's probably significantly worse, and residents hate it, and I know I did. I don't learn anything in a very high stress situation, it's just not an optimal place to learn. So we can change that with something like VR. Now what about simulators? I'll sort of move through these, I have a couple minutes left, but I want to share a couple of these papers. Maybe the simulators aren't the right answer. This is a question out of Queens that was done comparing this type of simulator to VR. Both groups actually scored, these are medical students who have 0 medical experience. And so they looked at both groups. The yellow or the triangle is the group that trained on the simulator. The blue group is the group that trained on the virtual reality system at Precision OS. And what they found was after training, look at what happened to the virtual reality group when they examined them on cadavers. They were significantly better, but actually almost by an entire year of residency based by the benchmarks that we use in Canada. What about this type of simulator? And the author of this study is actually here, and you know, kudos to him, Dr. Raman. He's a fellow at Cedars-Sinai. He compared these big simulators in residence and said, okay, you do simulation, you do virtual reality with precision, then we're gonna have both groups go to the cadaver lab, we're gonna record your video while you're doing surgery, and then we're gonna send that video to expert hip surgeons and see if they notice a difference. And this study is being submitted for publication, and what they found, the early results are, the outcomes were equal, that there was no difference in expertise. Let's go to the cadaver. I think this is the gold standard. We've identified this as a gold standard, but can we actually collaborate and compare one versus the other? This is a study done out of Columbia, and what they found was, again, randomized 2 groups, then the cadaver lab. They found that the outcomes were equal in the critical steps of procedure from soft tissue handling to instrument handling. Now this is perhaps the most important question, is can virtual reality actually impact patient care if you train in VR and then go to the OR? This is a study published in JOS. This procedure was done by an experienced surgeon. The implant was too small, placed in the wrong position. The patient was transferred to another hospital where the trainee actually practiced in our system. And what he noticed during his practice is that the number of x-rays he took went down. He was able to get faster in VR. Again, I don't use speed as a metric because every surgeon will tell you speed is not a metric of success. And of course, then his precision score went up. And what he did the next day was he was able to do the case by himself the next day on an actual patient. And during surgery, he actually used almost 8 times less radiation than the index surgery done by a surgeon who's been in practice. This to me is where we need to go with VR. So I'll wrap up by saying that probably a little bit second by second. So I'll pause there to say that procedural training is extremely complex and multifactorial. We need to evaluate it and maybe take a different perspective on how we should approach and implement VR. And the question that we're always asking is, can VR open Pandora's box? And I want to thank everybody for your attention, and I hope to see you in Winnipeg at some point in the near future. Thank you.